This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Mazen, who is head of our research department at the Institute. Welcome, Mazen.
Yes, welcome. Hi.
So we'll just talk about some of the things we've looked into, with particular attention to comorbidity indexes and how that's affecting the American healthcare system.
Yeah.
But before we get into this interchange, why don't we talk about your journey through life? And you were born in Syria? Where were you born?
I born in Saudi Arabia.
You were born in Saudi Arabia.
Yes,
I've
and
learned something. Really?
I finished my high school diploma from Saudi Arabia. Then I moved to Egypt. I studied at medical school at Egypt at University of Misr University for Science and Technology.
Yes.
Then I went back to Saudi Arabia. I did 1 year of internship training.
Yes.
Then I decided to have a chance to do my residency training at United States.
Yes.
I did the board exams. Then I came to United States, and I've been applying for residency.
Right, and now you're working with us as you do research.
Yes.
Okay. Now you don't have any connection with Syria.
I have many relatives
I thought
in
you
Syria.
were. You're not
yes.
Syrian? No.
I'm from Syria, but because of the system, my dad
but
needed
your
to leave
relatives
Syria.
are Syrian.
Yes,
You have Syria and
yes.
lots of relatives there.
I'm still Syrian, and my
Yes,
relatives
yes.
are Syrian. Yes,
And so it's a very distressing situation there now.
Yes,
is that a
it
fair
is.
statement? I hope that'll
Yes.
work out, and I know everybody wants that situation for the
Yeah.
Syrian people to improve. So we could say that. Well, all right. So we've done lots of. Different,
I'm from a
yeah.
city called Homs, and by the way, this city is almost destroyed completely.
Where is that?
It is in the middle of Syria.
What's
It is
how
called
would you spell the name?
Homs.
Homs.
Yes.
Are there jokes about Homs?
Yes.
No, I've heard
from
jokes. I
people.
mean, for the is the idea that they're sort of hard-headed. Is that the story?
Yeah.
That's right. Yes, and so they have a special. It's kind of like, I don't know, people from South Georgia. Maybe they've got some kind of I don't know, reputation or whatever. I don't know.
Yeah.
But people from Brooklyn have a reputation. People
Yes.
from wherever, Alaska, have a reputation.
Yeah.
People from your home city
From Homs,
are
the
very
city. Yes.
opinionated, right?
Yes. Everybody in Syria say jokes about.
All right. How about a
Homsi
quick
people.
joke? Can you give us one joke?
I can't
Not
remember
right
jokes.
now. All right. Maybe we'll all right. We'll have you back, and your mission
I left
is.
my country 3 years ago.
Yeah,
so
your mission
no
is to
jokes
think of a
now.
joke. Okay. All right. There are lots of, but the point's well taken, and the tragic story is the city's been destroyed. How many people lived there before it was destroyed?
Before there was about 1 million people.
1 million people.
Yes, now
wow.
there are about 3,000 to 5,000 only
That's
living
just
there.
a terrible story, isn't it?
Yes.
I mean,
all my relatives left that city. All of them.
there are all sorts of tragic events that happen. People have died and been just terrible,
Yeah.
terrible things happen. Right, every day it happens, and everyone would like to see that conflict resolved. I mean, I know you would, and it's a real tragedy there.
The average number of people killed every day is about 100 people.
Really
died every day, killed.
And it's
by
it seems to be going on in perpetuity. Is that no?
Yeah.
Wow.
Yes, the situation there is really very bad.
Yes. Well, we can all
And
hope
the
that
world isn't.
the world's
doing
not paying
anything.
attention. So this is a good chance to say they should pay attention to this terrible tragedy there. Right?
Yeah.
I hope that things can be resolved and we can make things better.
Right.
Well, okay. We can talk a little bit about the different kinds
Maybe
of
the
things
healthcare
we've looked
system
at. We'll
in
talk about
Syria.
the American. We could talk about the American healthcare system. We can talk about the Syrian healthcare system. We want to say anything about it? About how did it work in the past?
In the past, the government rule everything. Nobody can ask anything how it's ruled or
Yes.
how it's going. The healthcare system is run. The government put the rules, and the people should follow these rules.
And that's the way that it was sort of a top-down arrangement.
Yes, right.
Yes. So we can now, having said that, the way that system worked, we can consider some of the events happening in the U.S. Is that correct?
Yes.
We could
A
do that.
little bit, yes.
Now, we went through a number of different kinds of studies. We've had different kinds of interchanges about different things. And one of the things we're looking into, I guess, is the new structure of the American healthcare system, where the government is really going to regulate things in an enormous degree, more than has happened in the past. And one way they do that is by using something called DRGs. Now, what is a DRG? It's your test.
The DRG system is a system put by the government to gather
So
data.
it means diagnostic related group. Is that what
Yes,
it means? Yeah,
the
diagnostic. So
diagnostic
something that has a similar diagnostic etiology.
Yes, it is a program or a system to gather data from hospitals and to put a system to put a program for reimbursement and to do studies about how the comorbidities may affect the severity of illness and mortality.
Okay,
Yeah.
all right. So I guess what we're going to get into is some kind of arcane, complicated story. And this is the way the American healthcare system is changing. So in the past, let's say, pick your year, 1970, maybe 1960, there was sort of a fee-for-service arrangement. So if you came in, you're going to stay in the hospital for a week, well, it costs $100 a day. And if you could pay it, good. If not, you got charity. The same with doctors. So you see a doctor, he's going to charge you this. This is what it'll charge you if you could pay it, good. If not, you get charity. At least that's the way the system is supposed to happen. Now we've had this huge revolution. And what the government is saying is the amount of expenses are so extraordinary. The increase in cost, which is, I think this is a true statement, are just not sustainable. There's too much money being spent. We have to find a way to check these expenses. So the government has a methodology in place using these diagnostic-related groups to basically diminish healthcare expenses. I guess you could say that. Is that a fair statement?
Yes. The DRG system is the government put many DRG systems to for many purposes, and each DRG system can be used for one purpose. But the problem is we don't know exactly how the government put the details of that system. So and we need, when we ask about that, we need to read hundreds of pages to know some details of that system, but there is no clear description of how that system is.
All right, let's
going.
discuss this. Let's discuss where we're going with this. So, what we've done some studies at our institute, and we've looked at cases that had spine procedures. They basically had different kinds of spine fusion procedures, and we saw why those patients stayed a longer time in the hospital or less of a time, and we attempted to see if there's any kind of relationship between the time they stayed in the hospital and something called a comorbidity index, or comorbidities are they're coexisting diseases. So, for instance, is the patient diabetic, hypertensive, obese, sleep apnea, vitamin D deficiency, anemic? We put all these different variables in a little mathematical arrangement, and we looked at our patient, and we discovered things that seemed to be associated with a longer stay. We did that.
Yes.
We also looked at complications that were arranged to see if there was an impact of the comorbidities on the complications, and we came up with a certain set of facts from our patients. And then what we did is we attempted to compare our facts with the general methodology the government uses in their system to look at hospital compensation arrangements, to evaluate physicians, and to say what's good and bad, with the idea that what the government is doing it's moving away from this traditional fee-for-service arrangement toward some kind of pay for performance, I guess you'd say it that way. So you'd get a reward for a good outcome, and you'd basically be punished for a bad outcome. And to get that accomplished, it's going to be necessary to have an appropriate statistical underpinning for this, which would be using these DRG arrangements, which seem somewhat complicated. We'll talk about it in a little bit. The government is going to put a system in place where they can reassure the American people, reassure all the healthcare providers out there that they're on top of the problem and they're able to fairly reward or punish providers and hospitals about the kind of performance they're undertaking. So I think that's the ultimate idea and plan. Move away from fee-for-service toward this reward-based arrangement. Is that a fair statement?
Yes.
And to accomplish that, they have to have in an appropriate comorbidity index and an appropriate complication arrangement, so they can just judge things. Okay, now I think we're at that point. And so when we did our own personal study of the situation, we discovered that the ways that at least for our patients, it did not match with what the government had done. Is that a fair statement?
Yes, it is. Yes, actually, the DRG, some DRG programs are based on Elixhauser comorbidity index.
Yeah, there are several of them.
Yes,
the Elixhauser. Yes.
DRG. There are several DRG programs, and some of them are based on the Elixhauser comorbidity index. Elixhauser comorbidity index, we believe that it is not comprehensive.
Yes.
Because it measures only 29 comorbidities, but we found that our patients, the number of comorbidities that we collected from 300 patients that we studied, there are more than 40 comorbidities. And when we correlate these comorbidities to complications, we found that there are many comorbidities associated with complications. These comorbidities are not in the Elixhauser, and are not one of the 29 Elixhauser comorbidities. So we need more comprehensive comorbidity index. Elixhauser is not enough.
So let's discuss that a little bit. So what we're doing basically from our small little study is we're saying we're challenging at least a substantial part of the apparatus by which the government is controlling the flow of funds into the American healthcare system, and thus being able to regulate and in some circumstances ration healthcare.
Yes.
We're saying that this Elixhauser comorbidity scale, I know that sounds rather complicated, doesn't appropriately look at least our group of patients. It doesn't really reflect the influences in our group of patients as to how long they would or would not stay in the hospital. So having said that, we can go through each of these 29 variables and just say there's some things that are intellectually wrong with the government system. I don't want to get too tedious about it. I don't want to get too tedious, but I think it's fair enough to make a few general observations. The way that the government does this is they use something called an existentialist variable. That means something is present or not present. And
Yes, like anemia, for example.
That's right. We can pick anemia. Yes.
Yes, when we do our studies, when we consider anemia only as yes, no, we come with the very wrong results.
Yes.
But when we consider the severity of anemia and we classify the severity of anemia into 4 groups, for example, we find that the consequences of severity of anemia is different with the severity. So more severe anemia leads to more length of stay and more complications. So it's not enough to say these patients have this disease or not have it.
So what we're saying here, and this is an issue of consequence for the American people. Everyone depends on their health care. Everyone wants the best health care. It's unusual for people to say, as we've just said here, we want to raise the question about the government's methodology, about how they're doing this, how they're putting the system together. And we can go through, I don't know if we have enough time, to challenge the Elixhauser scale. I know it sounds funny, doesn't it? the Elix-Hauser comorbidity scale. We think there's some substantial problems with this, but this scale is one of a number the government uses to basically reward appropriate care or inappropriate health care. And so what at least we're saying is there are fundamental errors in this apparatus, and what it's doing, it's causing misapplication of healthcare resources in wrong directions. They're punishing hospitals that shouldn't be punished. They're rewarding hospitals that are and providers that should not be rewarded by the government system. And the problem we have is that it is extremely difficult to penetrate the bureaucratic veil around how the government is doing something. So if we're trying to discover how they actually are doing this, it's really complicated, isn't it? It's not easy to get any information, is it? Is that a fair statement? We
Yes,
try
it is,
to.
yeah.
It's not easy to discover what system the government uses to pay this money.
Yeah, it's not easy. It's very
And so
difficult.
what this means is the ostensive purpose of the Affordable Care Act is to basically diminish health care expenses. And everybody is suspicious. What the government is really going to do is it's going to ration health care. And they're going to take health care dollars from some people and give them to others. And they're going to do this with the idea they've perfected a system that can reward good behavior or bad behavior, and thus the patients will benefit from that. But what we're saying, at least in our initial look at the subject with our patients, is the scale that the method they're doing this with for a substantial group of patients has substantial fundamental systemic errors in it. And we could talk about some of them. Number one is the government is using an existentialist scale. Yes or no, is it there or is it not there? The second big area on this is, so if I can say it this way, what the government is trying to do is they say, you're a real sick person. We're going to factor in how sick you are in regards to the kind of treatment you received. And we'll be able to say effectively, well, you were so sick, it cost a lot more to treat you, thus, and the results were not as good, and we'll factor that into our apparatus. So, but we're saying, just to repeat our point, the system, the Elix-Hauser scale has lots of problems. Existentialist variable. The other big thing about this is discovering comorbidities, discovering how sick the patient is. How sick is this patient? And what the government depends on is just the patient's history or what can be extracted from the records. So for instance, if a patient was a smoker and he said, I don't smoke, then that would have a huge impact. If the patient smoked 6 packs a day, that would have an impact. It wouldn't be stated. If the patient neglects to discuss the fact that he has immune deficiency syndrome, then that has a huge impact. Whatever the patient does and does not say makes its way into the charts, we could have totally erroneous information. The other issue that's out there is the concept of a cut point. Now can you explain what a cut point is?
Actually, when we do a test in the labs, sometimes there is a range between the lowest normal level and the highest normal level, but we usually sometimes we don't have a cut point that shows the most significant relation with some diseases or some comorbidities or some complications. For example, with vitamin D, there are many references saying the normal level is 20. There are many other references saying it is 30. When we try to find a cut point that prolonged, under which the length of stay prolonged, we found the cut point was 17. So the cut point is the level under which the patient is going to develop some complications or consequences.
So what we've come up with, just to summarize what you've said, is rather there's from a statistical point of view, we can find an exquisite point in these numbers that where everything counts, this exquisite point. Well, in this Elixhauser scale, that was not put in there. So
Yeah.
the causal effect of a particular kind of complication is not put in there. Now, another thing in this scale is many important, as you indicated earlier, are left out. For instance, sleep apnea. Do you want to discuss sleep apnea? So the fact that it's not listed there is in the Elixhauser scale. They might respiratory, but not sleep apnea per se.
No, there is no sleep apnea, and there is no severity of sleep apnea, and severity of many other diseases. For example, not only sleep apnea. There is no vitamin D deficiency, for example. I think there is something that is not in Elixhauser system, which is and all DRG systems are not able to correlate comorbidities with complications. So when a patient develops a complication and that complications is directly correlated to one of the comorbidities, that's very different from another complications that doesn't correlate it to comorbidities. For example, wound infections can be correlated to diabetic patients, but the severity of anemia is not correlated to diabetes. So having some complications, referring these complications to comorbidities, I think this is also an important point.
Yes. All right. Let's keep bouncing the basketball on that subject. We found that sleep apnea has a huge impact on length of stay and thus expenses. The government doesn't pay any attention to it in this substantial number of patients. And one of the things to think about this is this is a comorbidity that has a big impact on how long the patient is going to stay in the hospital and whether the healthcare efficiency is going to work out. And the problem is that it's expensive to obtain the diagnosis of sleep apnea. And one of the things the government's healthcare system is doing, it's trying to limit a lot of the tests by which this diagnosis could be established. Moreover, often making these diagnoses require physician input into it. And the government has dramatically reduced compensation that could assist in making the diagnosis. So what's happening is a large group of people are getting a comorbidity that is so expensive to diagnose and so difficult to diagnose that it's not being entered into this mathematical construct. So
they're going to stay underdiagnosed.
Right. So we have this underdiagnosed. This is a substantial intellectual problem that goes on with this. Now, this kind of interchange in our little public conversation here is not something that I've seen before. We're not getting this kind of assessment is not reaching the public, and it's become in the past. This is the sort of thing that maybe was not such you talk about over the breakfast table. Wouldn't be something you'd normally have an interchange about comorbidity indexes. But what's important is the power of the government to influence everybody's health care has enormously increased. It's tremendous. That is the essence of the Affordable Care Act. The essence of that 2,500-page document with thousands and thousands of government regulations is the government is going to have the ability to determine what particular part of the health care complex is going to get financial rewards or financial punishments referable to particular kind of behaviors. And the government is asserting that it is capable, can do it. The bureaucratic apparatus is there. We can do it. Don't worry about it. Trust us. Everything is just going to be fine. And yet we make an inquiry here in Middle Georgia into some of the nuances of this. We have troubling questions that arise. And this is the kind of debate that needs to actually enter the public forum. And I'm hopeful that we'll have more interchanges about that. Now, tick. We can talk about a lot of things tonight. We don't have a lot of time left. One of the issues is too much health care and too little health care. And in Syria, was there such a problem? Did some people get too much care and some too little?
Actually, majority of people in Syria get too little care. Many people, if they want good care, they travel abroad. They go to Europe or United States to get treatment.
Yeah, so
there
what
is shortage
right,
in Syria,
right,
actually.
right. So what I guess I'm saying is, right now it is.
But by the government say everybody has the right to get the best medical treatment and
Yes.
the best the highest quality, and the government always say that each person in this country has the right to get the best treatment, but
Yes.
Practically we found nothing is there.
Right. Well, so I
We
guess
need to travel abroad
right,
to get
right,
the
right.
treatment.
What I'm getting into is this notion of what rationing is or is not, and some of the definitions that I think are going to be before the public. So, in Syria or other places, you'd say almost everything is undertreated. Nothing is overtreated. Very little is overtreated. The assertion now about the American healthcare system is one reason so much money is being spent is a tremendous amount of overtreatment. Thus, if the government stops overtreatment and just puts things right in the middle of the Gaussian distribution,
right.
that would not be rationing. So if there's let's say a 95-year-old terminally ill patient that's wants a facelift, I mean, okay, we didn't give the patient the facelift. I mean, you can't say that's really rationing the way we would understand it. So what the government is going to try and do, in many ways, in their idea of efficiency, is they're going to move toward appropriate treatment as opposed to over-treatment, and that will not be rationing. Other people would say, that would be one definition of what rationing is. Another definition is doing the maximum best for every patient. The maximum, anything less than the maximum best for every patient. With a doctor-patient relationship, anything that can't be done, that the family, the patient, everybody agrees is the appropriate thing. If the government won't let that happen, then that would be rational. So we have this kind of conversation going on about what's appropriate and not appropriate in regards to treatment. And that's a pretty complicated story, isn't it?
Right.
And I'm not sure we have good guidance on that. One of the things I've said in the past about this is the physicians have largely been excluded from, in my opinion, from any kind of discussion about what's happening with the healthcare system and the changes that are going on. It's true enough. There might have been some kind of pro forma interchange in Washington with this when the act occurred, but I think the physician influence on this was quite secondary to the to other interested parties such as insurance companies. Not too much physician input, I think, into the whole process. So that's a substantial problem, and we hope to continue, as you know, making inquiries here in Macon along those lines.
Yeah.
So we hope you continue doing this. Well, all right. Do you have any last comments on anything? You have any last comments on Syria? Do you want to make any statement about that, or hope for a good resolution?
I hope that the situation in Syria get better soon, and the government in the United States help us to have better to get better very soon. That's it.
Okay, that sounds like a good thing to say. Well,
Okay,
thank you so much for
thank you
coming.
very
We
much.
enjoyed having you here. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.